Hello, everybody, and welcome to this episode of the OncoPT podcast. I am thrilled today to have my first ever person to talk about proton therapy, which is so exciting. So without further ado, I'm going to go ahead and introduce our guest, and then I will talk a little bit about how I first encountered this guest. So Dr. Andrew Lee, welcome to the OncoPT podcast.
Thank you, Elise. I'm very happy to be here. Thank you for the invitation.
So I first met, I didn't really even meet. I got to see your presentation at the Cowtown Oncology Nursing Symposium a few weeks ago. And I have to say, I actually did my clinical rotation up in Plano. And every day I would drive past the road where they were, I think, actually building the center way back a few years ago. So it's so exciting that I finally get to meet and talk with somebody who's there at the center, like doing this life-changing work. So I'm really excited to have you on here.
It's my pleasure. Thank you.
So Dr. Lee, how did you first get into proton therapy?
So I first got into proton therapy many years ago now, when I was still on faculty at MD Anderson down in Houston. Mm-hmm. And, basically my chairman at the time said, we're going to build a proton center and mm-hmm. we're going to be the first center in Texas. And at the time, one of only 4 centers. And he said he'd like me to lead the clinical effort to try and treat the first patient. Mm-hmm. And so I had to basically, in conjunction with my physics colleagues and an entire team, kind of get a little bit more information and some practical knowledge, and visiting some other centers about what proton therapy is and the treatment planning process, and then finally institute the clinical treatment. And the first patient I treated was back in May 4th of 2006. Mm-hmm. And so it was some time ago, but it's gratifying to see how proton therapy has grown and how the technology has also grown.
Mm-hmm. And so you mentioned in your presentation, now there are multiple sites across the United States. It's definitely still not as common, but it seems to be growing. So before we get into some of that, can we talk about what exactly is proton therapy?
Sure. Proton therapy is a form of external beam radiation therapy, and most external beam radiation therapies are meant to treat cancerous tumors. Mm-hmm. And the difference is the most common type of radiation therapy is X-ray therapy. And just like low energy diagnostic X-rays, like when you have an X-ray of your chest or your arm or your leg, those low energy X-rays pass all the way through your body. But when therapeutic radiation, we use a much higher energy, and therefore it delivers a lot more radiation dose to tissue, including tumors. Mm-hmm. But it's still passing all the way through the body. And mm-hmm. so obviously you're going to get radiation exposure before, at, and after the tumor. Proton therapy is a particle-based external beam radiation therapy. So if you kind of go back all the way to high school chemistry, it's just a hydrogen atom where we take the electron off and you're just left with a subatomic particle. Mm-hmm. And that subatomic particle can be accelerated to really high speeds. Just imagine like basically 2/3 the speed of light. Mm-hmm. And when those particles interact with tumor cells or cancer cells, they can impact and damage the DNA of those cancer cells. Mm-hmm. And therefore, it's effective as an anti-tumor and anti-cancer therapy. But one unique thing about proton therapy compared to something like X-ray therapy, we can control where that dose goes into the patient. And most importantly, we can control it so that there's no exit dose. Mm-hmm. So the radiation on the way in is less, and then it's characterized by something called the Bragg peak. And it basically all the doses deposit over a very finite range. And then mm-hmm. most importantly, there's no distal or exit dose, which is probably the most important aspect physically of proton therapy.
In your presentation, I kind of had an idea of what proton therapy was, but what really solidified it in my mind was this baseball analogy you used. Mm-hmm. Could you share that analogy with my listeners as well? Because it drove home exactly just how powerful and potent proton therapy is that I never appreciated before.
Certainly. So thank you for remembering that. But as I mentioned, so if you think about a proton, it's a subatomic particle like any other particle.
Mm-hmm.
And so if we think about like a bigger collection of particles like a baseball, if that's just sitting at rest, like on the ground or on a table, it's really not going to do any damage. It
Mm-hmm.
has no kind of intrinsic energy of its own. But if you threw it very fast, like a major league fastballer, like Randy Johnson, I know I'm showing my age. Um, he had like 100-mile-an-hour fastball, and there was
Mm-hmm.
one video, you could Google it, where he hit this poor bird, and it looked like the bird disintegrated. And
Mm-hmm.
but the concept, all right, proton therapy is much more elegant than just throwing a baseball, but conceptually, the idea of just accelerating, a particle to very high speed so it can do some damage to cancer cells on the other end is actually pretty close to what really happens. And so just think about accelerating a small BB or a baseball, but it's just very, very tiny. And that's what proton therapy does.
I'm serious. When you said that Friday morning in your presentation, because you were like one of the first speakers, my mouth dropped. I had never ever heard that before, but it made so much sense as far as the power of proton therapy in getting so finite and detailed and precise when it comes to these cancer cells. It's amazing.
Yeah, well, it's interesting. So proton therapy, when I first started, and
Mm-hmm.
historically, it used something called conventional or passive scatter proton therapy. So it was basically a big spray of protons. So imagine like a
Mm-hmm.
big can of spray paint just spraying out.
Mm-hmm.
And part of what we do in radiation oncology is make sure that we're coloring just within the lines, right? But we're doing that with radiation dose, not with a crayon
Yeah.
or marker. And back in May of 2008, so actually 2 years after I started treating at MD Anderson in Houston,
Mm-hmm.
my team and we treated the first patient with pencil beam proton therapy in North America. And
Mm-hmm.
that's kind of what you're alluding to. So now instead of this big spray of protons that goes out into the
Yeah.
patient, we can spray one little spot at a time, and it may be only a few millimeters wide. And therefore, we can customize the dose very carefully, especially if it's an irregular shaped tumor or
Mm-hmm.
something near like the spinal cord or the brainstem or a very sensitive area. And that's not just true in 2 dimensions, but also in 3 dimensions.
Okay.
And so a typical tumor, may really take thousands of these little pencil beam spots to
Mm-hmm.
adequately cover. But computer technology and software, it's so fast you can't even follow it with the human naked eye. It's
Mm-hmm.
just incredibly quick.
So that was actually going to be my next question was to be that precise, it sounds like it would take a really long time to address all of or as much of the tumor as possible. How long do these treatments usually last for patients, like one session?
So, for example, when I gave the talk at the oncology symposium, the
Mm-hmm.
primary focus is on prostate cancer.
Yeah.
And so if we're just treating the prostate gland, which, in some cases might be a little about the size of a golf ball,
Okay.
that may take 3,000 spots.
Mm-hmm.
But the beam delivery time is probably 1 minute from the left side and 1 minute from the right side. And then that's it. Now we do so that the most of the time is spent setting the patient up so we're accurate,
Mm-hmm.
but we're talking about a 10 to 15 minute daily session.
Yeah.
There's going to be other disease sites where we have to treat a larger volume and the setup may be a little bit more complex.
Mm-hmm.
And, those may range between, 15, 20, even up to an hour in some cases, but that's usually when a situation, for example, we treat a lot of children and the really young kids, they can't really, stay still. And so they have to
Right.
be anesthetized every day. And so that obviously adds time to
Okay.
the overall treatment course. But in general, I would say, probably under 30 minutes and probably closer to 15 to 20 minutes in most cases.
That's awesome. So, what diagnoses are you treating with proton therapy?
So the types of cancers we have been treating has expanded over the last 10 to 15 years.
Mm-hmm.
It used to be thought that maybe you would just limit to, to very limited, but really almost anything that you might treat with more conventional X-ray based therapies, you can
Mm-hmm.
also treat with proton therapy and oftentimes in a more superior fashion. And
Mm-hmm.
so some of the disease might include things like brain tumors, tumors of the head and neck region, lung cancers, esophageal cancers, cancers that are affecting the upper GI tract like gastric tumors or liver tumors.
Mm-hmm.
And then in the pelvis, obviously we treat a fair amount of prostate cancer patients, but
Yep.
also things like rectal cancer and certain GYN cancers. Um, one area that we also treat a lot of is in soft tissue sarcomas. And
Mm-hmm.
these are cancerous tumors that are arising from, either muscle or bone or joint tissue or something of that nature. And so oftentimes they may be arising in areas that are very difficult to treat.
Mm-hmm.
But we're also treating a fair number of like breast cancer,
Uh-huh.
and which is pretty common, and then things like lymphoma. Historically, people didn't
Okay.
think that you would use proton therapy for lymphoma, but it's actually a very good
Mm-hmm.
treatment because a lot of those patients are getting a lot of chemotherapy too.
Yeah. So I feel like I'm hearing listener questions in my head already. And I bet someone out there is asking, what is the difference between using proton therapy, which is what we're talking about today, versus conventional radiation, like external beam radiation, which typically uses photons, correct?
Sure. That is absolutely correct.
So, what's the difference here?
Yeah, it's a question we're often asked not only by patients but also by healthcare providers that may
Yeah.
not be, as familiar with it. So one of the things is that when one of the basic things about radiation oncology we want to do is, if we could, we would want 100% of the delivered dose at the tumor or around it.
Mm-hmm.
And we would ostensibly want like 0% of the radiation dose to other parts of the body.
Mm-hmm.
And that the idea being is we can maximize the tumor control but minimize the side effects from the stray radiation dose.
Mm-hmm.
But typically it's not possible. I mean, it's with most external beam modalities, you're going to have some exit or some entrance dose and some exit dose.
Mm-hmm.
Whereas proton therapy, we minimize the entrance dose, maximize the dose at the tumor, and then again, as I stated, there's no exit dose. And so what
Mm-hmm.
that means is we're treating less normal tissue for a given tumor than a comparable X-ray therapy plan or a photon
Mm-hmm.
plan might. And that's important for a number of reasons because depending on what part of the body you're treating, it can minimize the side effect profile for the patient,
Mm-hmm.
and not only in the acute setting, but also long term.
Yeah.
And one of the things we're trying to do is not only maximize quality of life during the treatment, but down the road. And one of the ways to do that is try to minimize the side effect profile.
Mm-hmm. I feel like for the newer physical therapist or the therapist who is newer to working with patients in the oncology field, one of the things that's kind of hard to appreciate is just how extensive, pervasive the damage is when it comes to radiation therapy. And in this case, I am referring to more conventional external beam radiation. And it really wasn't until I had my first patient who I actually saw the exit discoloration. Like, she had a pretty significant, we joked about it, we called it a suntan, but she had darkening of her skin on her back from where her radiation for her breast cancer was entering through the front and exiting through the back. And for me, it wasn't until I really saw that I appreciated, oh, this is actually going all the way in, through, and then all the way out. And I mean, this was a patient who was undergoing breast cancer treatment for left sided breast cancer. And we're thinking about all the anatomy in there. I mean, this is potentially going through, of course, skin, muscle, fat, bone, but also heart, lung, and a lot of really important organs in this area that I feel like sometimes we don't appreciate the full extent of that when it comes to radiation therapy.
At least that's an excellent point. You can imagine the skin changes you're seeing, and
Right.
we've all, had it. If we ever had a sunburn, that's from the ultraviolet radiation of the sun, but it's
Mm-hmm.
relatively low energy and the dose is very low.
Mm-hmm.
And radiation therapy is using radiation doses that are orders of magnitude higher.
Mm-hmm.
And so if you can imagine, and that those skin changes may have developed acutely, but also there can be a late reaction, like
Mm-hmm.
the flexibility or the skin gets tough. I mean, we've
Mm-hmm.
all seen like ranchers and farmers that have a lifetime of exposure.
Yep.
But you can also imagine as you pointed out so eloquently, is what happens on the inside of the patient.
Mm-hmm.
So when one's lung or heart or your thyroid or normal tissues are being exposed, that's really probably going to have profound side effects later. And there
Mm-hmm.
can be a subtlety to that. Like when you take your breast cancer example, it sounds like, obviously I didn't treat that individual, but it's a situation where in locally advanced breast cancer, we're not just treating the breast tissue itself.
Mm-hmm.
We may also have to treat the lymph nodes that are,
Mm-hmm.
under the breastbone or in the underneath the collarbone and extend to the axilla,
Mm-hmm.
and sometimes even up in the neck.
Yeah.
And therefore, that all needs to be, and the chest wall is kind of it's not an easy place to treat because it's curved around, and so it's
Right.
hard to just treat that straight on without exposing a significant amount of heart and lung.
Mm-hmm.
And one of the areas that we've seen a tremendous advance over the last 5 to 10 years is our ability to use pencil beam to treat those complicated tumor sites or tumor
Mm-hmm.
targets, but spare the underlying heart and lung. And
Mm-hmm.
there's actually quite a bit of data, primarily from Mass General, showing how much you can actually functionally spare not only the lung tissue, but also the heart tissue.
Oh my
And there's
God.
a subtlety there because, that individual probably had to have chemotherapy as
Oh my
well as
God. Yes.
surgery, right?
Yes.
And that's a lot for people to go through when they're, so oftentimes it's called, in cancer care, multimodality therapy.
Mm-hmm.
You're not just getting one treatment, you're getting a litany of different treatments. And that each one takes a little toll on the patient.
Mm-hmm.
And at least I don't know if have you ever seen patients that have been getting chemotherapy at the same time as radiation, like for head and neck
Absolutely.
cancer?
Yes.
It's real tough.
It's
They have a
rough.
tough time eating and drinking, like the fluid, the
Mm-hmm.
hydration level. And a lot of that has to do with, if their oral cavity or just, their aerodigestive tract is getting treated, with radiation and chemotherapy.
Mm-hmm.
um, it can be pretty toxic, and it does improve cancer control. The studies are very clear on that.
Of course.
And so what we want to do with proton therapy in those cases, for example, is minimize the dose. For example, we're trying to treat like something in the back of the throat, like a tongue base or a tonsil
Mm-hmm.
cancer.
Mm-hmm.
A lot of times with intensely modulated proton therapy, we can minimize the dose to the oral cavity.
Oh my
And
God.
it makes a big difference. I mean, people, not only in the short term, but long term,
Mm-hmm.
you ever see a head and neck cancer patient, they always have a dry mouth,
Yeah.
like they're always just sipping on water, and they may have been treated 5 years ago.
Mm-hmm.
And a
Mm-hmm.
lot of that is from getting their salivary glands irradiated.
Yeah.
And it's not just, the big ones, the parotids, because these are important when we think about stimulated salivary function.
Okay.
If we, eat something savory, sweet, these come into play.
Mm-hmm.
But for resting salivary gland function, so like having a dry mouth or not, a lot of times comes from the minor salivary glands that, are around the mouth or underneath the tongue.
Mm-hmm.
And so it's a big issue to try and spare that.
It's so exciting, in the year of 2023. I feel like we are finally at a point where, generally speaking, across the oncology care field, we are now having conversations more about when you are done with cancer treatment, because we are
Mhm.
going to, cure your cancer or get to where you can live for months to years after your cancer diagnosis compared to what we were previously. And so this conversation has really pivoted towards, it's not that you're going to survive your cancer diagnosis, generally speaking, it's how long and what kind of quality of life are you going to live with now that you have finished cancer treatment. And I think proton therapy has a really exciting role to play in that, because we're finally at this point, like I said, not for everybody, not for every diagnosis, but this is much more of a real conversation for a lot of patients, which is so exciting.
Absolutely. I mean, it's a great point. Um, Even in certain select cancers now, when we think about what the prognosis was, depending on the stage,
Mm-hmm.
5 to 10 years ago, it may not have been very good. And
Yep.
now with advances in certain medical therapies as well as radiation therapies and more
Mm-hmm.
into surgical techniques, we are either curing those patients or extending their survival by many years. And that's an
Mm-hmm.
important consideration because
Mm-hmm.
you minimizing the side effect profile now becomes even more important.
Mm-hmm.
And you'd have to double check the stats on this, but the American Cancer Society has estimated that the number of cancer survivors going forward in this country is going to be, it's measured in tens of millions of
Yeah.
patients. And, that is going to be a huge population. And if they're suffering a lot of side effects from being cured, it's obviously not optimal from a medical perspective, but also
Mm-hmm.
from a societal perspective, it's a lot. I've got patients that they want to go to work every day, or they've got family they need to take care of, or
Mm-hmm.
they want to make sure, they've got, cattle they need to take care of. And I get it. And so anything we can do to minimize what's going on with them, but still get them well,
Right.
is important. And
Right.
so it's very gratifying to see that at times. Excuse me. The other thing to keep in mind is um, the population is aging, right?
Yeah.
The not only has oncology care improved, but things like our ability to address cardiovascular disease is probably a big one, or diabetes, or high blood pressure, or bad cholesterol, things of that nature.
Mm-hmm.
So oftentimes I'm seeing patients where they might be 70, 75, and they've outlived both their parents by a pretty substantial margin
Absolutely.
because they just had good primary care. But what ends up happening is now you've increased that person's life expectancy.
Mm-hmm.
There's also an opportunity to develop cancers as we age. It just happens. I
Absolutely.
mean, it's just kind of a point of fact.
Mm-hmm.
And so we're just going to have to deal with a larger population of cancer patients, not only with their first diagnosis, but also survivors. And
Mm-hmm.
more, we're seeing a lot of maybe second cancers. And I'm not just
Yes.
talking about a recurrence of their first cancer, which does
Mm-hmm.
see a lot of those, but patients that have gotten over one cancer 10 years ago, and then they've survived, and now they've got another one. And
Absolutely.
it's just a lot for a person to go through. I get it. And one of the things that we try and do at the Proton Center is making sure that whenever we're reaching out and touching that patient, is we're trying to minimize the impact while still getting them well for
Right.
every episode of care.
Right. One of the things you discussed in your presentation was, we know that radiation is really beneficial for a lot of reasons when it comes to treating cancer, both external beam, proton therapy, and all the others out there, right? But one of the real considerations that we do have, because we kind of touched on it, is that radiation therapy can actually increase a person's risk of developing a second cancer because of how it affects the tissues and whatnot. How does proton therapy come into play with that?
Yes, it's an important consideration. And, we obviously always have to counsel the patient that the treatment, it could be chemotherapy, it could be radiation, may have some other ramifications, such
Mm-hmm.
as different kinds of secondary cancers.
Mm-hmm.
And so all ionizing radiation therapy does have the potential ability to lead to a second cancer. Now, typically that's much later in life. It could be 10
Mm-hmm.
years
Mm-hmm.
later, 15 years later, something like that. Um, but studies have seemed to indicate when that you compare patients treated with proton therapy to those treated with X-rays or photon therapy, the risk of developing those secondary cancers, years later, is substantially less in the
Mm-hmm.
proton patients.
Mm-hmm.
Sometimes by over half. And a lot of it, I think, has to do with the amount of normal tissue that's being treated or
Mm-hmm.
unintentionally treated or exposed to radiation.
Right.
So if we take the prostate cancer example, one of the most common forms of external beam radiation is called IMRT or arc therapy, and it's using photons or X-rays, and it does a good job because it uses many beams to target the prostate gland, but that radiation has to get in there somehow. So you're going to have some entrance dose and some exit dose.
Mm-hmm.
And so what ends up happening is a typical prostate cancer patient, they're basically getting a low dose radiation bath to their whole pelvis,
Yeah.
even though the prostate's getting a very high dose of radiation, which is what you need for optimal tumor control.
Mm-hmm.
Whereas with something like particle-based therapies like proton therapy, instead of using all those dozens of beams, I can just use a straight left beam and a straight right beam, and they don't exit out the other side.
Yeah.
and therefore we can minimize the exposure to the average prostate cancer patient's pelvis. Um, the equivalent, probably the difference would be almost 20,000 pelvic x-rays worth of radiation. You understand what a pelvic x-ray is. So imagine getting,
Yeah.
20,000 pelvic x-rays over the course of a month and a half. I mean, that's how much extra radiation you get on the photon side compared to protons.
That's wild.
Yeah, it's a lot of energy.
It's,
It's a lot of dose.
oh my God. It's, and unfortunately, it's no wonder, like I said, it's very unfortunate. It's almost no wonder that some patients will go on to develop these secondary malignancies as a result of that exposure. So, one of the really, and I know like most of your conversation at Cowtown was prostate specific, but you brought up a really exciting study or series of studies, I can't remember exactly, regarding esophageal cancer and how proton therapy is being used pre-surgically, and we're now seeing better surgical outcomes for patients undergoing esophageal cancer. So, can we talk a little bit about, it's, again, we've been talking about the amazingness of proton therapy and, decreasing a person's risk of like secondary cancers and some of the more acute, even chronic side effects of radiation therapy we tend to see. But like, let's talk some post-op.
Yeah.
How is proton therapy affecting that?
Well, thank you for bringing that up. I mean, it's actually a very good example, um, that's showing how proton therapy can minimize the toxicity profile, not only for the radiation piece, but the other parts of the therapy.
Mm-hmm.
So one common sequence of therapy for esophageal cancer is something called trimodality therapy.
Mm-hmm.
And it usually involves getting chemotherapy and radiation therapy first, and then going on to an esophagectomy.
Mm-hmm.
Now, the preoperative chemo radiation, it's not a walk in the park. And then the esophagectomy is a big operation. I
Mm-hmm.
mean, anything up in the chest is a big operation. But and so now you've done, pretty profound preoperative therapy, and then you're going to do a big surgery. There's going to be some perioperative and postoperative risk after that, and that can
Mm-hmm.
include things like problems with, pulmonary function. That can include issues with the heart, and I'm not talking about just a heart attack, but going to atrial fibrillation or a funny rhythm or any number of things. And what the studies have seemed to indicate is that if you use proton therapy as part of the preoperative treatment, so give chemotherapy with proton therapy,
Mm-hmm.
and then go on to esophagectomy, those patients overall tend to have better outcomes in terms of the perioperative side effects or the postoperative side effects.
Mm-hmm.
And that can include things like, things like ARDS, which is an
Yeah.
acute respiratory syndrome that can happen,
Yeah.
issues with their heart, like not only while they're in the immediate post-op period, but beyond. And at least in one study, when compared to X-ray patients, the proton patients had a shorter hospitalization stay.
Mm-hmm.
And so they were able to get out of the hospital earlier, and you had fewer patients that were in the hospital for very long periods of time.
Mm-hmm.
And as you know, those folks can get pretty deconditioned over time.
Absolutely. And again, from the physical therapy side of things, of course we want decreased hospitalization, like everybody wants that. But the amount of time that a person is going to spend in the hospital and then has to recover from
Yeah.
afterwards, in addition to all of the treatment side effects that they're experiencing, and probably had a little deconditioning even before they were diagnosed because that process was already happening within them. It's amazing to consider just how much better these patients are going to be overall in so many different domains of their existence. It's wild.
That's an excellent point. I mean, obviously for the patient, if you think about it, if you're an employer, for example, and one of your staff gets an illness, you've invested a lot of time and effort and resources to have that staff member, be a contributing member of the team. And obviously no one wants to see, their people at work or their friends get sick. But if they do have to go through something like that, you want them to get back to work and functioning, as quickly as possible within reason. So that's part of it. But the other thing is, just because someone's back, doing what they're supposed to be doing, whether it's taking care of their family or being at work, they may not be operating at 100% capacity, because as we know, cancer therapy can take a toll on a person.
Yep.
But there's also, think about, no person is an island unto themselves. They have a network of family and friends that might be also supporting them.
Mm-hmm.
So it's a situation where, let's say a spouse has to take care of a sick spouse, and, they may have children at home, or they may have a job outside of the house,
Mm-hmm.
and they have to take time off from that in order to take care of the sick patient.
Yep.
So now you're talking about an effect that's basically spreading through a good portion of not only the family, but also, to a lesser extent, society.
Absolutely. No, the community impact is absolutely something to not underestimate, especially, we're here in DFW. Like, that's one of the things I really try to hone in when I teach, because when I look at a patient, when I'm working with them, I know, like, it's not just the patient I'm working with, it's their family, the kids. I work with a lot
Yeah.
of moms, and they're involved in their kids' schools, in their churches, in the different volunteer, like, the community impact of cancer and the side effects of cancer treatment cannot be overstated. Like, we talk about this all the time. I'm really passionate about that.
Yeah. Well, I mean, as you should be. I think it's a very important consideration. You brought up the kids. That's an interesting aspect because, if you think about it, when it's tough to see anyone, but especially a child going through a cancer diagnosis.
Mm-hmm.
But obviously, one or both parents likely are going to have to spend a lot of time not only taking care
Yep.
of their sick child,
Yep.
but also the siblings. It takes a toll on them to see, their brother or
Yeah.
sister going through all that. And um, but one of the things that we've seen is that, kids go through this treatment, and either they're able to continue through school while they're going through treatment, or return to school, and in some cases, whatever extra curricular activity they were in, and whether that involves athletics or band. I remember one patient he was a drummer, and he was, one of the things he did is after he finished his treatment, he wanted to give a little drum concert, and
Oh my God.
I have to find that video because it was pretty impressive. He was a good drummer. But
Oh my
stories like
God.
that really, make me appreciate, what we're doing and be proud of what we're doing.
Mm-hmm.
Um, we, back before we began treating patients, a lot of the pediatric cancer patients in the DFW area, to access proton therapy would have to go all the way to Houston or to out of state in some cases.
Mm-hmm.
And since we've been here, basically we've become sort of a referral center for those pediatric patients, which is fantastic because not only I
Oh my
think we
God.
do an excellent job treating them, it just makes it so much easier for the parents and also the siblings, and also for the child because they don't have to move; they can go home, they can
Mm-hmm.
be around their family and friends. If they have a dog or a cat or a turtle, they can see that animal every day, and so I think it
Mm-hmm.
makes a huge difference.
Yeah. Pivoting a little bit, what are some of the things? Because, I mean, you and I, again, we're in DFW, we have access to this.
Yeah.
There may be some therapists listening who they don't have experience with proton therapy, or maybe they're now practicing in an area that is referring patients for proton therapy. What do we, as rehab professionals, need to know, need to understand about proton therapy?
I would say one of the things is that it's an opportunity for um, not only getting patients better, but minimizing the side effect profile and functional
Yeah.
outcomes,
Mm-hmm.
right? And that's very relevant in the therapy world because and that could be something as simple as minimizing dose to portions of the CNS system so that their coordination's a little bit better,
Mm-hmm.
or minimizing radiation exposure to a part of their GI tract so their hydration and nutrition status is better, things
Mm-hmm.
like that. But keep in mind, there's no magic bullet in oncology, few and far between, and
Mm-hmm.
so there is going to be times where there may be some side effects from any therapy, But I'd like people to keep in mind is that the potential side effect profile may end up being lower for
Mm-hmm.
proton therapy.
Yep.
The other issue is oftentimes we're dealing with patients that have already received therapy and are dealing with some issues from that, or they're dealing with functional issues because their cancer has returned
Mm-hmm.
after treatment, and
Mm-hmm.
that's a difficult situation. But oftentimes we're called upon to evaluate those patients and to see whether or not we can provide more treatment, either for a curative intent
Mm-hmm.
or to palliate a symptom.
Yeah.
Because maybe they've already gotten quite a bit of radiation to a part of their body with X-ray therapy, and it's just going to be too much to give more X-ray or photon therapy. But maybe we can do it with proton therapy and help provide some relief in that regard.
Mm-hmm. What are some of the acute side effects for if we're working with a patient who is currently undergoing proton therapy? What could we potentially expect to see in that patient?
Yeah, a lot of times it just depends on the part of the body.
Mm-hmm.
Obviously, I mean, there's going to be some sites where really people aren't going to have any profound side effects. I mean, the majority
Mm-hmm.
of my patients continue to work full time, drive themselves, do other normal daily activities.
Mm-hmm.
But you're going to have other patients who may have other side effects. Like, for example, a breast cancer patient, they still may get somewhat of a skin reaction to the treated
Mm-hmm.
area.
Mm-hmm.
Hopefully not exiting, obviously, but to the
Yeah.
treated area, because a lot of times the involvement of the tumor is actually involving the dermis or right underneath it. And
Mm-hmm.
certainly lymph nodes could be very superficial as well. And so understanding that a lot of times that even if they get that skin reaction, we need to support the patient through that. But a lot of times it's going to heal up. It's just going to take a little time after the fact.
Yeah.
Um, and then also just, we may see patients that are dealing with um, either acute side effects or late side effects following the treatment. And some of those
Mm-hmm.
side effects later on um, kind of happen slowly. It's a gradual decline. And
Mm-hmm.
then the next thing you know, they're having trouble like bending their leg or something like that. And
Mm-hmm.
we have to rule out the possibility that it's due to a cancer recurrence
Mm-hmm.
and, what is actually happening. And I
Yeah.
think that's an important consideration. But in general, I would say, for the majority of patients you might be seeing after proton therapy, it's a similar situation to external beam radiation with
Mm-hmm.
photons,
Mm-hmm.
but we'd like to think that the side effect profile and the impact on the patient would be less.
Yeah. Yeah. One of the big side effects that I hear from many of my patients is yes, we see those local effects of the radiation therapy, and this is not specific to proton therapy, but the fatigue that they experience is tremendous. What do you see with fatigue and proton therapy?
Yeah, so in general, I think the fatigue level is actually pretty minor, at least for the patients that I take care of.
Cool.
That is also a very site dependent and stage dependent kind of thing because,
Mm-hmm.
for example, if someone's getting concurrent chemotherapy and radiation, whether it's protons or X-rays, it's tough on a person, and so they
Yeah.
may need more rest, and that's kind
Mm-hmm.
of understandable. It's also largely a volume related issue. So the more normal tissue you're exposing, even to low doses of radiation, can make
Mm-hmm.
one fatigued over time.
Okay.
The individual may not experience it right off the bat, but throughout the course of therapy, they may say I'm having more fatigue, and we get that. And so we understand that people need more rest while they're going through this, and that's true for any external beam radiation.
Mm-hmm.
The other area is if they're getting a portion of their CNS system treated,
Uh-huh.
brain and things of that nature, that could be fatiguing in and of itself.
Mm-hmm.
But again, it could be with proton therapy, minimizing the dose of the normal brain parenchyma may help minimize some of those effects.
Mm-hmm.
Um, along with it, one thing about external beam radiation that sometimes I tell patients is it's kind of like having a part-time job that you don't want to have,
Yeah.
right? So they still may be trying to go to work, take care of their family, doing, run errands, do other things. And then there's this, usually any radiation therapy is a Monday through Friday
Mm-hmm.
situation.
Mm-hmm.
And, even if it only takes 15, 20 minutes, you got to get there, and dealing with
Yep.
DFW traffic
Yep.
is tiring in and of itself.
Yep.
Um, and so it's great that people want to do that. And it's great that I think something like proton therapy can help them do that.
Mm-hmm.
Um, but, sometimes people just need to take a break because, hopefully it's not a forever thing. We
Right.
get through it, get some time to convalesce, stay physically active as much as people can. I mean,
Mm-hmm.
I think that's an important consideration because, if they're napping too much and not getting physical activity, I think it inhibits their ability to actually tolerate the treatment. And then their normal wake sleep cycle gets really disrupted, and that's not good.
Yeah. Yeah.
Obviously, people need to get solid sleep when they can.
Mm-hmm.
Um, there's also subtleties if you're getting treated in this area, for example, um, and you're having difficulty sleeping, it could be for a number of reasons.
Mm-hmm.
One of them could be if you have a lot of secretions. It's kind of like having a cold all the time.
Yeah.
And so that can make it difficult to sleep, especially if people kind of are on the borderline of having sleep apnea anyway. And
Yeah.
so I'm usually tuned into, you got to ask the patients though. So taking a good history is probably one of the most
Mm-hmm.
important things.
Yeah. Where can we find more information about proton therapy? Again, let's say I have a patient who's coming to see me and is about to start proton therapy, maybe even is going through or finished proton therapy. How can we, the rehab professional, find more information about it?
Yeah, it's a large topic, and it just kind of depends on the case. One area would be our website. It's Texas Center for Proton Therapy.com.
Mm-hmm.
And we go through some of the basics about what proton therapy is,
Mm-hmm.
some of the disease sites we can address, and some of the technology that goes behind that, and how to get more information. We also include links for other national websites where people can look to see kind of a broader scope of proton therapy in the
Mm-hmm.
U.S.
That is so exciting. How many centers are there now? Just
I've
ballpark.
lost count, but I think the last time I looked, it was around 30,
Okay.
which is interesting because, when I first started, we were like one of four. And
Yeah.
then the very next year, we were one of five. And then, my prediction back then is maybe there'd be 12 proton centers in the U.S. And
Wow.
obviously that's, we're way past that. And I think some of the important aspects of that is one, ours is a huge proton facility. I mean, we have a
Mm-hmm.
large cyclotron, 3 treatment rooms, large gantries that, each one weighs like 100 metric tons.
Oh my
So
God.
massive units. But over the last 5 to 10 years, there's been a growth in kind of compact units
Mm-hmm.
where, they can't do everything that a big, proton machine can, but they can
Mm-hmm.
do about 80% of it, for
Oh,
example.
that's awesome.
And they tend to be less expensive. You don't need as much room. So for a lot of medical systems, both academic practices as well as community-based practices, they've been electing to install these one-room facilities. And that's important for access, right? Because
Absolutely.
you know we're seeing a lot of patients from out of state because they don't have access to protons, and so
Mm-hmm.
even a single room in a metropolitan area that was near them might have been helpful.
Right. Yeah, that's a really good point. And that's, it's one of the things, and I'm sure people are asking this question too, because I had the same question until you answered it at Cowtown, which is I was told when I first started practicing that insurance did not cover proton therapy. Now, whether that was true or not, I don't know. But what is kind of the state of proton therapy and coverage these days?
Yeah, I would say a lot of cancers and a lot of insurance companies are covering proton therapy. For example, traditional Medicare is probably one of the better ones because they understand that they're probably carrying or going to be carrying that person or their client for the longest period of time. It could be several
Mm-hmm.
decades.
Yeah.
And so for them, it's a good value proposition because if we can do a good job taking care of the patient and getting them over their cancer and also minimize the side effect profile,
Mm-hmm.
you amortize that over 10 to 20 years or 30 years, it's a good deal.
That's
But now
awesome.
even a lot of the private payers and insurance companies, depending on the diagnosis, they understand the value to them and to their
Yeah.
patient, obviously to their client. But it's not 100%. Nothing ever is. But we take care of a lot of that for our patients. We do a good job of saying, this is the clinical rationale for this case,
Mm-hmm.
and here's the supporting literature or scientific studies that support the use of proton therapy for this case. And so we're able to get a lot of those decisions in favor of the patient.
That's awesome.
Yeah.
Very, very cool. All right, one last time. What's your website?
It's Texas Center for Proton Therapy.com. It's all just one string.
Yay.
And
That's
but
awesome.
if people are interested, they can check it out if they're in the area. I'm hoping, I don't know when we'll be able to do this, but we used to have people sign up for tours so they could see the center on the weekends.
Mm-hmm.
I'd like to get that back going again. It was hard during the pandemic, obviously, but
Of course.
yeah, there's because it's one thing to talk about it, and I didn't want to bore people with the slides, but to be able to see it in person and to see the level of technology
Mm-hmm.
that's being used to help patients, there's really no substitute for that.
Oh my God. I mean, like the pictures gave me an idea of just how big and how, I mean, I felt like I was seeing the super collider in CERN a little
Yeah.
bit, but like, oh, there was definitely some nerding out happening at our table when we were watching your presentation.
So, Elise, have you not visited us ever?
No, and I was going to ask if your offer
Oh
was
boy!
still there
All
because
right,
I
I'll
would
tell you
love a
what. You need
tour.
to, get a group of your colleagues
Oh,
and
perfect.
please reach out to me, and we'll get
Yes.
something set up.
Oh my God, I'm like fangirling right now. It's gonna happen, y'all, and like I'm gonna make it
Okay.
happen, Dr. Lee.
Yep.
Oh
If you
my
get
God.
some pictures, maybe you can post them as part of your podcast or something.
Absolutely. Absolutely. Well, Dr. Lee, thank you so much. This was such a fun, informative conversation. You hands down started off that conference on such a good note. Like that presentation jazzed me up so much. And I'm just so excited to know more about this because this has been within the last few years that this is really available to my patients. I'm really, really excited about it.
Lise, thank you so much for this invitation. It was wonderful, and I appreciate your passion regarding the topic. So thank you again.
You're welcome.
All right.